Hello guys, it's me Dr. Ayaz Ahmed. I am working as an aesthetic dermatologist. Today I have selected another important topic for you. The name of topic is erythema multiform. Hopefully you will learn and subscribe my YouTube channel. So by definition it is a self-limiting cytotoxic dermatitis resulting from cell-mediated hypersensitivity reaction. Most commonly to a certain drug and infection. These are actually the causative agents of erythema multiforme. It is present clinically as a macular or papular or arterial lesion, acral iris, and target lesion. I will discuss target lesion later on. So mostly it involves palm, hand, oral and genital mucosa. So these are the target lesion which are pathognomonic sign of erythema multiforme. These target lesions are characterized by the three zones. Number first is the central dusky zone. This one is the central dusky zone, and second is the edematous zone, and third is the erythematous zone with clear edges. So these three zones are these three structure which is present in a target lesion. These are the pathognomonic sign of erythema multiforme. This picture describes clinical features of erythema multiforme. You can see these three zones. Here is the central dusky zone, upper is the erythematous zone, the audematous zone, and third is the outer erythematous zone with clear border. So it is most common in the hand, mouth, and mucosal area. For example, you can see the lips here is involved. There are small macule or papule like lesion, eroded lesion with some erosion and blister formation involving the oral cavity. In this picture you can see target lesion with clear border, mostly present on the dorsal surface of hand. So etiology, there are lots of etiological factors, but ultimately they leads to immunological bases which have been noted. For example, association with HLA, B62, B15, HLA, B15, HLA and DR53 gene have been noted. Autoantibodies in skin and circulation are also noted, and autoantibodies against epithelial cells and desmoglein 1 and 2 with suprabasal acanthosis are noted. Delayed hypersensitivity reactions are noted, and herpes simplex virus association here in case of erythema multiforme, which is a major culprit of erythema multiforme, are noted. So there are some triggers of erythema multiforme. This list includes, number first is the viral infection. There are lots of viral infection, for example herpes simplex virus, mycoplasma infection, acquired immune deficiency syndrome, adenovirus, cytomegalovirus, hepatitis B infection, infectious mononucleosis, lymphogranuloma inguinale, Milker's nodule, mumps, ORF, poliomyelitis, psittacosis, variola, vaccinia, and varicella. These are the viral infections which are associated with erythema multiforme. So there are some bacterial infection also noted, including Rickettsia family of bacteria. Fungal infection, for example histoplasmosis. There are certain drugs, for example vaccination. There are some contact reaction are also involved in case of erythema multiforme. Erythema multiforme is also caused by some miscellaneous agent, for example carcinoma, lymphoma, leukemia, granulomatosis with polyangiitis, lupus erythematosus. Another name for lupus erythematosus is Rowell syndrome, polyarthritis nodosa, polymorphic light eruption, pregnancy, premenstrual autoimmune progesterone, dermatitis, sarcoidosis, and X-ray therapy. So these are all causative agent or etiological agents for erythema multiforme. There are some antibiotics, for example cephalosporin, which include cefotaxime, erythromycin, penicillin, ampicillin, quinolone, rifampicin, sulfonamide, which include cotrimazole and sulfadoxine, pyrimethamine, sulfones, tetracycline, and thiacetazone. So these are antibiotics which are involved in erythema multiforme like eruption. Antifungal or anti-yeast preparation which are involved in erythema multiforme. These are gracilin, nystatin, and terbinafine. Antiviral agents or antiviral drugs are abacavir and nevirapine. These are antiviral agents which are involved in erythema multiforme like reaction. Non-steroidal anti-inflammatory drugs, these are fenbufin or ibuprofen. Moreover, paracetamol, pyrazinamole derivatives, example antipyrine, phenylbutazone, phenazone, salicylic acid, and sulinidec are also involved. There are certain metals, for example, arsenic, bromide, gold, iodide, and mercury are involved in causing erythema multiforme like lesion. Anticonvulsant drugs are barbiturates, carbamazepine, hydantoin derivatives, lamotrigine, trimethadone. These anticonvulsant agents are involved in erythema multiforme. Another category is antihypertensive drugs, for example, furosemide and hydralazine. Minoxidil, thiazide diuretics are also noted. Drugs acting on central nervous system, for example, lithium, menacerine, phenothiazine, and trazodone are also involved. Miscellaneous drugs are allopurinol, chloro, uh, chloropamide, and codeine, cyclophosphamide, danazole. There are lots of other drugs which are involved in the causing erythema multiforme like lesion. So topical agent triggering erythema multiforme include sanitizers, balsam of Peru, chloramphenicol, iconazole, ethylene ediamine, and furazolidone, mefenite acetate cream, rubber gloves, and nickel. So these are the topical agents involved in the erythema multiforme like lesion. Pathological features include necrotic keratinocytes. Pathology actually is similar to Steven Johnson syndrome or toxic epidermal necrolysis or fixed up eruption. Squamatization and disc keratosis, edema and vasodilation, rarely extravasation and blister formation are noted. Differential diagnoses are fixed up erection, Steven Johnson syndrome, and toxic epidermal necrolysis. It is the first differential. Second differential is the graft versus host disease, photodermatitis, severe vasculitis, coagulopathy, and gluconoma syndrome, lichenoid cytotoxic dermatosis. So these all are differentials of erythema multiforme. This picture describes the histology of erythema multiforme. You can see upper outermost epithelial cell, there is a necrosis in outermost layer. Also liquefaction have also been noted. There is also necrosis of basement membrane zone area. Histological features, here you can see epidermal necrosis, dermato dermatophic cytotoxic lymphocytes, liquefaction, basal cell degeneration, and apoptotic cell and hematoxylin are also seen. Clinical features includes clinical features of erythema multiforme minor. These are characterized by papular urticarial simplex form or iris or target lesion. It accounts for 80% of cases. Target lesion have three zones: central dusky, middle edematous zone, and third is the erythema with well-defined edges. I have already discussed this point. Common in extremities, but it may be involved in palm, trunk, and oral mucosal membrane. Lesions are red, flight, macule or papule-like. Size range from small 1 to 3 cm. and there is a photo aggravation of lesion. Second category is the localized vesiculobullous form, and third is the erythema multiform major. So, vesiculobullous form, it is less severe, present as the erythematous papule or macule, often with central bulla, herpes iris of Batman, which is known as the marginal ring of vesicle. Lesions are acral and few in number. Third category is the erythema multiforme major. It is a very severe illness associated with extensive target lesion and mucous membrane involvement. Fourth category is the atypical cases, and fifth is the Rowell syndrome. The atypical cases lesion may be stationary or enlarge slowly over several weeks or several months. Cases usually develop continuously. Erythema multiforme along Blackshaw line have been reported. Occur in a setting of generalized exanthematous pustulosis. Moreover, Rowell syndrome comprises allele-like lesion, immunological finding, example ANA antibody, anti-ALA or anti-Rho antibody, and positive RA factor are seen. Differentials of erythema multiforme. The differential of erythema multiforme are fixed drop eruption and lupus erythematosus, IgA pemphigoid, autoimmune bullous condition, stem cell transplantation, urticaria vasculitis, and Kawasaki disease. So now let's come to the management of erythema multiforme. Symptomatic treatment for localized papular or bullous form. For ocular involvement, refer to ophthalmologist. In case of toxic epidermal necrosis-like feature, high dependency unit or ICU or BUN unit are needed. Prednisolone 30 to 60 mg per day with tapering in 1 to 4 weeks are required. Antiviral therapy before eruption has appeared, and for a long-term prophylactic 200 mg TDS needed. Thalidomide, Dapsone, azathioprine, mycophenolate, mofetil, and cyclosporin are the drugs which are used in erythema multiform like lesion. Thank you very much. Stay connected and subscribe my YouTube channel.